Dr. Hector, welcome today to this Q&A. And today we're going to talk about fertility treatment add-ons, which is a term that has been coined by the HFAE, which leaves some patients from the UK a bit confused about treatment and what to do, but it's something that maybe other patients from outside the UK are not so familiar with. So I think we can just maybe bring some clarity to the topics and just help our patients make up their minds about what it is and if it can help them or not.
Mm-hmm. First of all, Andrea, thank you a lot for inviting me again. I like a lot to be here and to be able to share information with the patients and to discuss these topics, all of them, because I think in this process, the key is information. Once we're informed, we're able to make decisions, and with the decisions, we can move forward. Therefore, I'm always happy to be here and share with you some points of view. Regarding this new advice in the UK, there's one big difference in the thing is the Spanish Society for Reproductive Medicine, for gynecology and obstetrics. And as I was from also in Germany, the German as well, they don't follow this way like they do in the UK. There are some guidelines regarding minor topics, pretty much just how you deal with diagnostic in infertility. In this direction, there are guidelines, but regarding treatment lines, what you should do, what you shouldn't do, or what you do in the compassionate therapy for patients, it's never been touched there. That pretty much has something to do with the very big limitation we have in Germany, in Spain, and in many other countries. And is how to produce scientific, valid information based on trials and the type of trials we have. And that's something that we need to clarify to the patients and so they can understand what this information means. This new thing shows the patients if there are some things that are going to be offered that are tested on basis from randomized control trials. And a randomized control trial is no other than a study that works this way. We put two populations and we compare them doing different things. And we decide randomly, without any wish, ganz randomly, very randomly, which one goes here and which one goes there. And these have shown us in medicine to be a very potent and effective tool to bring new knowledge and to tell us what to do with these new things. If things are good or not good. And once that's plain, that is the next topic. Can we do something like that in reproductive medicine? And that's the problem, not really. In Spain, we have the huge problem that all studies that has to be with embryos are not going to get an admission from the ethical committee. It's very big, too big, but very rare, because we are there manipulating lives and then putting lives into risk on the basis of a study is something very, very difficult to get accepted from an ethics committee. And that's why this type of studies, to prove if the things we do are good or not good with the patients, is not going to be able very soon. I hope with the time, I really hope that our ethics committees get a bit new energies from new people wanting to know more and be less conservative. And then perhaps we'll go in this direction. But at this moment, Germany, Spain, no possibilities of going in this direction. And since it's not possible, then the government can tell you, okay, base all of your things on these things that you cannot do. That's why we don't have it.
That is such a good point, because these treatments, according to HFAE, are treatments that haven't received what they say is evidence enough, which, as you mentioned, they say for it to be good evidence needs to be through those randomized controlled trials, which is incredibly difficult to do because some of these treatments, it's almost impossible to blind patients and doctors. Patients and doctors will know what treatment they've had. So it's very difficult. And I think another difficult aspect is the fact that they are only measuring success as a live baby. But I think a lot of these treatments as well, they may help patients move closer to that goal. So it's a small impact in the overall system, a system that is in itself very complex, as we know. So I think it can be really difficult for patients to come around and understand the classification that is being given to add-ons. But can you give us some of the examples of treatments or devices, things that are being considered as an add-on?
I would really like to go through this place, and I'm going to I have them open here because I'm a bit of a freak on this thing, and I would like to read them all so we can just go through them if you agree.
Yeah, I would love that.
So wait a second. Here, first of all, artificial egg activation through calcium developers. First thing, we will need to compare if the egg will get activated better and fertilize better if we use calcium. Not going to be approved by an ethical committee. Assisted hatching, once again, manipulation of embryos, not going to be approved very soon. Elective freeze all cycles. In this particular case, I think we should point it from another point of view. It's not that we freeze embryos because we want to. There are some moments when we need to freeze the embryos in order not to transfer them properly. And that has to do with some approach that I have here in this case, for example. To say something, a patient with a polycystic ovary syndrome would normally produce a lot of estrogens and a lot of follicles. And in some countries, in order to make a fresh transfer, they're going to be a bit more slow with the stimulation. So the estrogen levels stay lower. So I might be able to make a fresh transfer. In this particular case, knowing that patients with polycystic ovary syndrome are more likely to have a lousy egg quality, I rather try to obtain as much as possible and then resignating to the fresh transfer. What does it mean? I stimulate in order to obtain as much eggs as possible, so I can obtain as much as embryos as possible. And then I risk not to transfer fresh if the estrogen levels are too high. And the thing is, if they're too high, I cannot transfer because I'll produce if ovarian hyperstimulation syndrome. Then in this context, I rather not transfer fresh and freeze the embryos and then transfer them just to control these things. Other things, patients where we have been making transfer and we discovered that the implantation window, another add-on, has shown us that the implantation window is not proper. In this particular case, I can also now do a fresh transfer because the embryo is going to be ready when it's ready, but endometrial perhaps not. And then I need to displace it. In this case, I'll need as well to make a frozen transfer. Therefore, so doing it pro forma always is something I don't think it's very good, but specific cases need a specific answer for them.
So what they're doing is they're rating possible interventions, but they're also rating processes, the way things are done, and rating medical devices. And I think it's getting incredibly confusing. So I wasn't aware that elective freeze-all cycles was on the list.
This list is very, very interesting. They talk as well as embryo glue, which is just a medium. It doesn't really affect the embryo. They talk about things that are pretty much known that may have an effect. For example, intrauterine culture to see if you have bacteria. And that's a very logic thing. If you have an infection, then you're not putting the embryo in the breast hard if you're giving it back while an infection. So I think some things that are there are very difficult for me to interpret what are they meaning with Islam. So, for example, once again, intermediary culture. What should I do with that? What are they meaning? Should I forbid it? Should I try and not try anymore? For implantation of genetic testing, and that's also a very, very complicated thing because with this, we might be allowing women not just to get more pregnant, because that's not the principle of the PGTA. We're allowing women in all the ages to avoid having to have an abortion due to a genetic condition of the baby. And with people that work in fertility, you as well, Andrea, know how hard it is for a woman that's been trying so long to get pregnant, then having to say, okay, wait a second, I achieved it, and now I have to end up this pregnancy. That's devastating for a woman. Therefore, for me, it's a bit complicated to understand how should I avoid a woman at something that may result in her wellness and well-being. I don't know.
I think it's really difficult. And if we think, for example, about the time-lapse imaging that they have here, I see it as a tool to help embryologists. Mm-hmm. And in medicine, we get these new devices all the time. And they help us do our jobs better. I don't understand why these would necessarily be considered an add-on if it's helping the embryologist select the best embryo.
Me neither. It's like going to a shop, having a phone, wanting a better camera, and someone telling you shouldn't have the better camera because that's proven that's better. It's a bit complicated. Nevertheless, what I do think is good, because I think it's always a good perspective to everything, and I do encourage this asking again and telling, is it really good? I think confrontation and discussion, it's always really good. It brings us further. If we always do the same and no one tell us, hey, wait a second, why are you doing this? Then we might end up making the same mistakes without knowing it. So it's not that I think that this type of confrontation is bad, all the way around. I think it's good. The thing is they leave us without tools to prove what we do. Because our experience, our data that we assume are not going to be accepted. And that's what I have in my hands. When I make my cycles, I see I'm very, I'm very squared, and I need to have everything under control. And I always have a personal statistic that I renew every single week when I know how many eggs, how many embryos, how many pregnancies, who's pregnant, which week, everything. I know in which state every one of my patients I treat it is. And with this information, I can see how it behaves a bit. But that thing that I have has no meaning at all because it's not a randomized control trial.
Yeah.
This small thing there, it makes me a bit, okay, that it doesn't mean that's not good, what they say is good, but it gives us the feeling from the other side that what we do is not work. Yeah. And then you feel a bit in the middle, trying to offer things for patients, but not being able to do it because they feel we're doing something wrong.
It's almost like we need to rethink what outcomes, apart from pregnancy and the baby, matter to patients, and what is the best way of measuring them and getting evidence of those that might not necessarily be those randomized controlled trials. And I think that leads me to the next question, which is, in healthcare, we're used to using and making recommendations that are off-label all the time, right? So, for example, metformin, which is approved for diabetics, we use it for PCOS. as off-label as hundreds of other things just because we found that it works.
And based on the physiology, because PCOS patients, they have an insulin resistance. Then metformin helps with this insulin resistance and then make them better. It's not that we go crazy and say, okay, let's do this because why not try it? We make some decisions actually in information and physiology and facts from things that we already know how they work. So that's not like we are just sitting and wondering, okay, which new software I would like to know to make something different. It's not really like that.
So how do you navigate this, and how do you best help your patients make up their minds? Because it's a complex issue, even for us healthcare professionals. How can we help patients learn more about these treatments, devices, interventions, which is all in this bag, and help them make up their minds about how they want their treatment to be?
Keywords: as much as needed, as least as possible. That's the keyword. Efficiency must be the point of the arrow from all our interventions with patients. We need to try always to do the best with the less. That's the key. And what I do think is also good from this type of publications, like what we're discussing now, is that they do make patients think a bit before they do things. Mm-hmm. And that's very important because not every patient needs everything. It needs to be an accurate, sensitive, personalized decision with every single patient. It's not about me sitting here like some type of commercial and telling you, look, this is the offer, pick the best. It's not about this. Mm-hmm. It's about getting to know my patient and really knowing where is there. And that's also very complicated with the patient, I must say, because some patients that come, for example, to me to egg donation, and they say, I want this, this, and this. And I go back to follow the patient and I say, okay, wait a second. But you haven't been able to be pregnant at all, never, because you haven't produced one egg for your life. Therefore, I don't need to test your implantation window from the very beginning, or see if you have some immunological test, or see if you have some other things, because you haven't made a transfer at all. Let's focus on producing a good embryo for good quality and transfer it. And if we don't succeed, then we'll see. And that's what I mean from rationality. It's not about aiming ants on the wall with nuclear weapons, but also not the other way around, trying to kill a bear with a mace. That's what we need to do in this direction. And the most important thing is always transparency, be open, and say things clear without funny words or statistics, or because then you lose them. We need to we workers in healthcare, we need to know, and not every person that's sitting in front of you know what we're talking about. And then as soon as you say, this study from this side is been doing this way, and we decide this, they lost you. They don't know any longer what you want from them.
I remember too many years ago when I was diagnosed with MRKH that I did lots of research on what the next steps should be. And I had a big file with all the possible options. And I thought I really knew what was my next step until I met a doctor who was so knowledgeable, but also so open to communicating. And he reviewed everything I had, and he talked to me about the pros and cons of each of them. And I said, actually, what is best for you? I think it's something that is not there on your file. And this is why I think it's best. And I think that open communication is key, because patients will go on Google, they will read all of these things. So if we have a clinical team that is open to communicating, discussing, and then making that personalized treatment, I think it would be the best way forward.
I think the word itself is already very powerful. We are consultants. This idea from the doctor that sits on the chair and says, Andrea, you do this. This is what you need. That doesn't exist anymore. we are consultants, we give advice, we share information, and we make decisions together. And that's the way it is. If my patient is unable to make a decision, then I'm doing wrong because I haven't given her enough information or haven't stated properly for her to make a decision. Patients might be empowered and encouraged to make decisions themselves with the information that they have. That's the way I see it, and I think a lot of doctors work this way at this moment. I'm very proud of that because I think that's the only way. That's the change we all need to do.
And Dr. Hector, one last advice to someone who has maybe been reading about add-ons and doesn't know what to do next. What would be your last piece of advice?
My last piece of advice is more than reading about add-ons. What we need to do is to really classify my problem. Before I decide what I need to do to be better, I need to see what's been going wrong to improve it. Mm-hmm. And in this direction, we'll be more likely to know what's going to help me. Because this is a very emotional journey for all of our patients. That's for sure. And when emotions get together in decisions, it starts to get blurry. That's why we need to try to stay objective, not cold, objective, and see where can be the problem. And that's very easy to see when you see the process. Mm-hmm. Then it's not the same thing, a woman who hasn't get pregnant because she's not producing any eggs, than a woman who has 3 transfers from embryo in day 3, then a woman who has 3 transfers from embryos in day 5, then a woman who has abortions in week 10, then in week 15, and in week 25. These all processes are very different, and knowing what's been happening, which information I have from my previous cycles, from my previous attempts, led me to know which things I might need.
I think that is a great piece of advice. Dr. Hector, thank you so much for clarifying this complex topic, and I'm sure it's going to help lots of people who are trying to conceive.
I hope that it's some information there. And as always, I'm very open to all these discussions and to talk about new topics. The more information our patients get from us, the better we're doing the work.